Welcome to Oncology Spotlight, a podcast where we interview those who are working on the war against cancer, brought to you by the OncoAssist team. Thanks very much for joining us today, Natalie. First and foremost, could you mind introducing yourself?
Yeah, absolutely. My name is Natalie Vokes. I'm an Assistant Professor of Thoracic Oncology at MD Anderson Cancer Center in Houston, Texas.
Excellent. And can you tell us a little bit about the study you presented here at ASCO 2023?
Yeah, so this was a collaboration with Regeneron, and this was looking at the ctDNA data from their clinical trial Empower Lung 1. This was a trial of metastatic lung cancer patients who were treated with cemiplimab versus chemotherapy with high PD-L1. And on this study, they collected blood at baseline, at 3 weeks, and at 9 weeks. And they used a tissue-informed, tumor-informed ctDNA assay to look at the ctDNA levels of the tumor at those time points. And what we found is that compared to baseline at 3 weeks and at 9 weeks in particular, there was kind of a clear separation of patients whose ctDNA levels went down versus those who went up. And by 9 weeks, it actually looked fairly bimodal. So most patients were either increasing or had almost completely cleared or had completely cleared their ctDNA. And not surprisingly, what we saw when we looked at outcome is that did translate into how well they did overall. So patients who had cleared their DNA by 3 weeks or 9 weeks did very well with very good long-term overall survival. Patients whose ctDNA was going up didn't do very well and had much more rapid progression. And those that were in the middle had kind of middle overall survival outcomes. One of the big questions in immunotherapy treatment is what do we do with patients who have equivocal scan results? So patients who have a mixed response or who have stable disease. And what we saw is that the stable disease patients kind of divided into two. Okay. Some had their ctDNA go up, others had their ctDNA go down. Excuse me. And their outcomes segregated as you would expect. So even if patients had stable disease on scans, if they had their ctDNA clear, they did very well.
Okay, excellent. That sounds really good. And I know you do a lot of work in the informatics space. So do you see any future in terms of AI and the new technology coming in how we can improve cancer treatment?
Yeah, I think that particularly in immunotherapy and other treatment contexts where the relationship between the treatment and response is very complex, there is some scope for AI to help us. We know that immunotherapy only works in some patients. We have no idea who those patients are. And it's probably some integration of the biology of that tumor, that patient's immune system, how the immune system is perceiving the tumor, what the tumor is presenting to the immune system, and we have no clue right now how to tease that apart. I think the next phase in research is going to be more intensive molecular profiling of these tumors and of the immune system, and that will generate so much data that we will almost certainly need AI algorithms or machine learning algorithms to kind of integrate that and find the signal for us. Okay. I think the other scope for AI is going to be in integrating novel data types. There's a lot of work in applying AI algorithms to slide images or to radiographic images, to radiomics, and extracting biology from those images that we can't perceive with the eye. Okay. And I think when you take those scans, you apply AI algorithms to those and then apply that to predicting an outcome, we are starting to see some results and some improved predictive capacity by integrating that in. And I think in the future, it's going to be all of those together. Yes,
excellent. Very, very good. And have there been any other studies at ASCO 2023 that have caught your eye?
I think the whole lung field is talking about ADAURA. I think that's been the biggest data to come out, was the overall survival data from that, which looked at adjuvant osimertinib for patients with resected tumors. We had known in the past that this was a very positive hazard ratio for event-free survival, and now we have the overall survival data to show that these patients also live longer. I think we still will need to see how it compares in those patients who went on to receive osimertinib on the placebo arm, so kind of a focused subgroup analysis of those patients. We also will want to see how many patients on the osimertinib treatment arm go on to never have their disease come back. So are we actually curing any patients, or are we simply delaying their disease recurrence till later? But certainly I think that this will be a practice that most clinicians will adopt.
Excellent. Brilliant. Well, thank you very much for your time. Thank you.
Thank you.